the founder of the Youth Advocates for Global Health Association. We are a youth-led nonprofit organization, and our vision is to establish a united global youth community committed to advancing global health equity and fostering human health and well-being. Through initiatives centered on research, community projects, policy advocacy, and international engagement, we strive to shape a healthier, more equitable future for all.
Yeah, good afternoon, everyone. My name is Matthew Yu, the Vice President of YAGHA. Today we'll be exploring the topic of rare diseases. We're very delighted to be joined by Dr. Durhan Wong-Rieger. She is the President and CEO of the Canadian Organization for Rare Disorder, the National Alliance of Rare Disease Patient Organizations in Canada. She earned her PhD in psychology from McGill and previously served as a professor at the University of Windsor. She serves as chair of Rare Diseases International, the global alliance of rare disease patient groups, and has held leadership roles in international working groups on global access to rare disease therapies and universal health coverage. A longtime advocate for patient-centered health policy, she has worked extensively on early diagnosis, equitable access to orphan drugs, and integration of rare diseases into national health plans. Dr. Wong-Rieger is also a certified health coach, a frequent lecturer and trainer, and the author of several books and numerous articles of patient engagement and health systems. And I'm sure she'll tell us a little bit more about her work as well.
Following the presentation, we will have a Q&A period where webinar participants may submit their questions using the chat function. But without further ado, let's give a warm welcome to Dr. Wong-Rieger. Thank you so much for joining us today.
Well, thank you very, very much for the opportunity to be here. I was delighted to actually learn about this organization. I think Youth Advocates in global health is certainly needed at this time, and the fact that you're actually providing, information to your audience is really very exciting, and I was very pleased to be able to provide this, certainly on a topic that I have a lot of passion for, and that is rare diseases, but equally passion for engaging patients as advocates, but also ensuring and promoting, equitable access to what would be diagnosis, care, and treatment. So thank you very much for the opportunity. The topic I want to talk to you about is rare disease across the globe. And I put in the question, is equity achievable? Can we make sure that we've got access to diagnosis, care, treatment across the globe? What we're going to talk about, though, interestingly, is why and what does rare mean in different parts of the country? Why some rare diseases cluster, how countries detect, prevent, and treat rare, and where do the drugs fit in and where they don't fit in? So it isn't all about drugs, but certainly drugs are a very important part of it. I think, as Jonathan and Matthew indicated, I am President and CEO here in Canada, but I've had some global roles as well, and currently still serve as the president of the Asia Pacific Alliance of Rare Disease Organizations. So work a lot with the rare disease groups and healthcare systems in the Asia Pacific area, and certainly in the Southeast Asian area. What we look at is some of the low middle income countries. And so how does rare differ there? So interesting is that rare diseases, we like to say they are increasingly common and also increasingly rare. So what does that mean? If you look at the literature, it suggests that there are between 7,000 and maybe 10,000 rare diseases. And there are new ones added every year. And frankly, about 3/4 of them would be identified as having a genetic cause, though many do not. And basically, they have been used as a basis for developing what we call orphan drugs. We'll talk a little bit more about that. Drugs that are designed specifically for these small rare disease patient populations. But across the globe, if we look at rare diseases, about 85% of them, of the diseases themselves, would be considered what we would say be very rare. That is, they affect fewer than 1 in a million folks. On the flip side of it, maybe 4/5, 80% of the number of persons that have rare diseases would actually fit into the most common rare diseases. So this is the a little bit of the challenges here, is that many of the diseases are very, very rare. However, the bulk of the patients, as you might guess, would fit into the most common rare diseases. So about 4% of all rare diseases consist of 80% of persons affected. So where does rare disease came to be defined? How did they come? Certainly in the literature and the development of it, two major sources: the U.S. Orphan Drug Act, and in the European Orphan Drug Legislation. So drug legislation actually drove the formal definitions of rare diseases. In the U.S., a rare disease was brought forth by advocacy actions from a mother who had two children with rare diseases, a congressman who really stepped in to help raise the awareness, and a key actor who helped, again, publicize the importance of rare diseases back in the 1980s. And since then, it has given rise to the development of drugs specifically for what they define as diseases that affect fewer than 200,000 persons in the U.S. So at that time, a finite number. In Europe, similar legislation came into place around 2000, and they kind of made the definition of it more around a prevalence number, so fewer than 1 in 2,000 persons. Any disease that affected fewer than that, and also identified as having no ongoing treatment, no approved treatment, and actually also very much in need of a treatment. And this worked. So rare diseases was really defined around what are we going to do to provide incentives for researchers and for drug companies to develop treatments for the diseases, which at that time, almost none of them had any treatments. I mean, it worked, and as we say, the incentives worked. There are now close to 1,000 treatments for rare diseases coming out of the U.S., and certainly in Europe, close to about 500 or so. However, if we take a big step back, rare diseases are not necessarily defined the same way across the globe. And I really want to just sort of look at the Middle East as a really important example, where rare really refers to diseases that affect a very small number of people, but those people are not necessarily defined as an incentive for drug development, but are really those populations, those diseases that are found in the community because they are related to what we call indigenous genetic homozygous conditions that are oftentimes perpetuated because of consanguinity, because of a close relative marriage. So you've got these genetic mutations that are found in specific, oftentimes subpopulations, and because those subpopulations, really have a high rate of intermarriage, these conditions then perpetuate, and they then become problematic in terms of their impact on people's health and in terms of the health system. And so, in each of these Middle East countries where there's a high degree of consanguinity, the goal is really to be able to identify what these conditions are, to provide genetic genomic testing to identify persons who are affected by the rare diseases, and then to put in programs that would help to reduce the potential incidence of these diseases as difficult diseases. What happens, if we can talk about in terms of these rare conditions, is that if, each parent or each person in a couple carries one of the genetic mutations, same genetic mutations, and they marry, they have at least a 1 in 4 chance of having a child that will have a serious form of the diseases, oftentimes a very debilitating or oftentimes a lethal form of the disease. So the goal is, if we can identify people that are affected, provide genetic counseling, provide support in terms of being able to avoid having a child that may have a double mutation, and therefore reduce the likelihood of having the condition become symptomatic in the family. This is true in many communities, but in the Middle East, this has become very much a part of how they have developed what we would call a rare disease program, but based on trying to identify, genetic variants that are, indigenous to the population. I mean, this has also been used in Italy. It was used for identifying families with thalassemia, and again has reduced the incidence of thalassemia, a very serious rare blood disorder, from a high prevalence to where it's been almost non-existent as a disease, not necessarily the genetic variant itself, but not having children that are going to be affected in terms of having two copies of the gene. So a lot of the policies on rare diseases out of the Middle East have grown out of the desire to actually improve the diagnosis, screening diagnosis, and the early prevention of many of these diseases. Out of it also, though, in many of these communities, has also been a gene therapy program. So if you do have a genetic, mutation, can we correct that mutation? And a huge amount of very effective work around genomic sequencing, genomic testing, but also moving into a gene therapy program that has actually created opportunities. If you look at Qatar, look at Bahrain, look at Oman, many of these have been able to develop very effective gene therapy programs that would actually help to treat the genetic cause of the disease. That actually will span, hopefully, into gene therapy beyond those specific rare diseases. Some of it's still in very early stages, but a very important and a very different, definition of rare and the approach to the importance of it. Still the same. What do we do for very small populations that are oftentimes seriously affected, but oftentimes neglected unless we focus on them? Just want to bring up just briefly to understand that in the Asia Pacific region, there are across these countries many different definitions of rare diseases, some of them based in the same way as the Middle East is, where you've got high indigenous populations that will have specific mutations. Many of them also based in terms of what the European, North American definitions would be, and trying to focus, in fact, as well, on creating programs of care and treatment, also access to very specific treatment. Japan, China, Australia, within this region, often, having programs that are somewhere in between kind of what a Asia Pacific might be and kind of what the more European-based programs have been. Canada as well, not having an official definition, but working very much from a rare disease orphan drug model. How do we get access to, how do we develop orphan medications that are specific to these populations? So what we know, though, is the definition, though, of what is rare is now changing in the sense that in many common diseases also have rare subtypes, subpopulations, and you will know many of them. If we think about cancer, one of the early diseases to identify that was breast cancer. So breast cancer now is not just breast cancer. Breast cancer has many, many, many subtypes that are defined by their very specific, genetic markers. The BRCAs we've always talked about, HER2 mutations we know very much for. Also in lung cancer, in chronic myeloid leukemia. All of these are diseases where there are patient subgroups that their disease, they have the same cancer, shows up in the same part of the system, but the cause of that disease is a very specific mutation, which then directs how their cancer not only develops, but luckily how their cancer can be treated. Because as I was saying before, now that we understand a gene, and if we can understand what that gene does in the body to cause the kind of symptoms or the kind of debilitation that it does, if we can either treat the effect of that gene, so what are the effects in terms of the body, or importantly, if we can actually affect the gene itself, can we change that gene? Can we remove that gene? Can we add a different gene that would make up for the deficiencies of the gene? Suddenly you have a very, very targeted treatment for what looked like in the past is a very common condition, but now has a subtype which can be very precisely treated and oftentimes treated to the point where, the disease, for all effects and purposes, is no longer causing destruction, is no longer causing symptoms, and may not be continuing to have a risk profile into the future. We hesitate to say cure just because cure is such a big word. It's hard to say. But what you'll see is that, within this notion that rare diseases, exist inside of common diseases, it goes beyond cancer. It definitely goes into other disease areas, including, blood disorders, including arthritis now we know, including, things like diabetes. Again, we have very specific subtypes of diabetes. So in addition to the known rare diseases that we would often talk about, Fragile X, cystic fibrosis, Tay-Sachs, these are what we call the traditional rare diseases. These over here are diseases that are common, have a lot of different causes, but not necessarily a genetic cause, and so you don't have the same kind of subtyping. But then you have the others, right, that are in fact possibly have some chronic conditions, some environmental conditions that are also creating subtypes, as well as the ones I say that have very specific genetic subtypes. So the line between rare and common diseases is not such a rigid line. The treatments, the diagnosis and treatments that we're learning with rare diseases, and especially since we say in the genetic genomic realm, are really helping a lot in terms of being able to identify and treat much more common diseases much more effectively. So as we say, there are increasingly rare genomic mutations. You will have heard hopefully about the Human Genome Project, where we've been able to now sequence the entire human genome. We now have, thousands of genomic mutations that we have been able to identify, so that within these common conditions, we now have many identifiable genomic mutations. We don't necessarily know what all of these mutations do. We don't necessarily have the ability to actually treat all of them, but we can see Alzheimer's, more than 20 genetic mutations and more than 200 plus gene combinations that influence it. 90 mutations linked to Parkinson's. My husband, has just recently passed from Parkinson's disease. And quite frankly, we call Parkinson's a diagnosis of exception. When we cannot figure out what it is that's causing those kinds of symptoms that you have, dystonia, and the kinds of challenges that Parkinson's demonstrates, you end up saying, okay, we don't know what else caused it, we'll call it Parkinson's, because it's got a constellation of symptoms that are common across these patients. But because we're just classifying a bunch of, symptoms, it makes it very difficult then to find targeted treatments. Now we're finding there are genetic mutations, and we are going to be seeing, very specific treatments already being developed for specific subtypes of Parkinson's. So many conditions that we thought, okay, we're just going to treat in terms of symptom management or in terms of the organs that they are affected, we can now look at, what are the genetic underpinnings, and some of the genetic underpinnings may affect different organs, different parts of the system, and yet have the same genetic cause, and ostensibly would be amenable to the same genetic treatment. So this is very, very exciting, and we are already beginning to work into this realm and into the future. It is not that far away where one might actually get a genomic sequencing for a disease that you may experience, and looking for the genetic variations and then trying to treat the genomic underpinnings as opposed to treating the symptoms of the disease. Gene therapies, of course, is the big thing that everybody talks about. This is the big promise, right? Once we have identified genomes and genetic mutations, the question is, what can we do to directly affect the gene? Not just how do we make up for the challenges that the gene is causing in terms of the system. And we've had, many examples now of diseases which are very amenable to either removing the gene and manipulating the gene so that we will change it to become much more functional. We have instances in which we're adding the gene, like in spinal muscular atrophy, so that we will make up for what is missing in the defective genes that are in the system. We also are going to be looking at the ability to directly manipulate the gene in the cell. Luxturna is one of the diseases that causes blindness for often children, late adolescence, early adulthood, who have the disease. And this is a gene that is injected directly into the cells of the eyes, which again will compensate for the lack of the functioning gene. So these gene therapy breakthroughs are coming. Some of the more common diseases that we have had, but also some of the very, very rare diseases are actually being amenable to the direct either manipulation, replacement, or substitution of a gene. So this is really not only cancer, but as we say, in many rare diseases. In fact, Canada was one of the places where we had the very first gene therapy that was brought to market. This is for a very challenging condition called familial hypercholesterolemia, hypercryomenia, which is a very low functioning in terms of the blood for very specific kinds of a condition, which results in very, very high symptoms. And this is the gene therapy that was actually developed in Canada, which would make up for the condition. It was marketed. It was at that time extremely expensive. In fact, more expensive than I think the market was ready for, though I think, quite frankly, the gene therapies that we're having today that actually work are really, not even more expensive than this initial gene therapy. It came out at $1 million. So this is what the gene therapy did not succeed on the market. It was withdrawn from the market. But it is an example of one of the very first gene therapies and the challenges that it takes now in terms of being able to bring it to market. This is one of the most effective gene therapies that we have for spinal muscular atrophy, a disease which leads to, progressive muscular deterioration. Children with this very severe form of disease will often die by the time they're 2 years old. There was a treatment that was developed that could be injected, but importantly, there has now been a gene therapy that actually, again, can make up for the defective gene. The challenge when it came out cost about $2 million. Up to $3 million in terms of getting access, had to be delivered by the time before the child was 2 years old. And in those early days, we had a lot of, advocacy, GoFundMe campaigns to try to get these babies who are identified with this disease access to the gene therapy as soon as possible. A lot of fundraising that took place, not just in Canada, but across the globe. This is a very interesting case of a pair of twins in the Ontario area, where in fact they were misdiagnosed, which happens a lot with rare diseases. They're often mistaken for much more common diseases. And by the time it was actually diagnosed, they had in fact progressed beyond the age in which a gene therapy would be available to them. They were over the age of 2 years old. So this is, something that today would probably not happen. Today we have newborn screening. So when a child is born, all children are given a test for spinal muscular atrophy. If they're diagnosed with the condition, there are further tests to see the seriousness of the condition. If in fact they do have SMA, across Canada, they're offered the opportunity to have a gene therapy that can actually not prevent the disease from being symptomatic. And many of our children now today that are born with SMA identified at birth, I shouldn't say many because there are very few every year, but do get identified, do get access to gene therapy, are actually developing with almost no difference to a child with no disease. So this is a huge, huge breakthrough, but it took a while to get access to it. Many children, suffering up to then. A different disease that some of you may know about is called butterfly disease, epidermolysis bullosa. This is one of the most famous child advocates for this condition. It's called the butterfly boy. They're called butterfly children because their skin is so delicate that it tends to, erupt into blisters. They need to be, as you can see there, they need to be wrapped oftentimes with salve, with cellophane, with gauze over them. And they often die from infections. He actually had, which was very important, he had a stem cell transplant where they took out the stem cells in his bone marrow, treated the stem cells, replaced the stem cells with functioning stem cells that were not infected, were not diseased, but he later died of the side effects, the infections, because during the time you do a stem cell transplant, you have to remove you put the body into a very, very high risk of getting infections. You remove the immune system. He died in 2018. Today, in 2023, was the first gene therapy that was approved for these butterfly children, where the gene therapy can be spread on the skin, and it would prevent the skin then from developing the blisters that are part of this disease. There's still a lot of challenges with the gene therapy because the skin sheds all the time, so it has to be constantly reapplied, so it's not a perfect solution. What we do know is we say, overall, in this day and age, there's a huge promise of innovative transformative therapies. The challenge is that, being able to get access to them. The therapies, though, not only can treat the disease, they can get you better early diagnosis and therefore prevent the disease. They address not only the symptoms, as we say, but the cause of the disease, therefore reducing secondary disease complications, disability, early death. The challenge, as we have kind of hinted all the way through, is that these are oftentimes costly therapies, and the challenge of getting access to them is not straightforward. The challenge actually begins, as we show here, with trying to get a diagnosis. It takes up to 5-7 years to get a diagnosis. Most patients in Canada with a rare disease will have gotten 4 or 5 misdiagnoses and therefore delayed access to an effective treatment if there is one, but oftentimes getting treatments that may further exacerbate their disease, or in some cases cause significant harm to the disease. So this is the challenge that we have, is that it's a very complicated, long journey, and even when there is a treatment, it may not be that straightforward, as we've said, to get access to the treatment. You have to be identified, you have to be diagnosed, you have to get to a specialist, you have to be able to identify what the right treatment is, and then, of course, there's still the cost of the treatment. What we do know globally, even though all of these diseases are rare diseases, may be somewhat differently defined in different countries. They do exist across the globe, and across the globe, a common need is to actually be able to provide early diagnosis, screening support to these patients. Also across the globe, there's a huge need to be able to provide specialists and to get access to care, and if, when possible, getting access to the treatment. So this past year, the United Nations has had a declaration on rare diseases. They've created now a resolution on rare diseases with the WHO. So we're moving forward in terms of having global recognition, global support for calling on countries to develop rare disease strategies, and for having support from across the globe to be able to raise awareness, which is the first part, and also then being able to invest in these diseases, oftentimes trying to conform universal health care to include rare diseases. In Canada, we have been very fortunate in that recently, a year and a half ago, we had the federal government, create a strategy, a national drugs for rare disease strategy, recognize the challenges of getting access to these conditions, recognizing that in many cases it requires the public drug system to be able to pay for these diseases, recognizing the huge impact that it may have on a drug plan budget. The federal government created what they call then is a funding strategy for drugs for rare diseases, a 3-year plan, and provided, $1.5 billion within this plan, given most of it directly to the provincial governments with several objectives. One is, of course, to improve patient outcomes and sustainability in terms of access to the medicines, to try to be able to have greater consistency across the countries, because in Canada, like in many countries where there is not a national drug plan, oftentimes your access to treatment depends on what province you lived in, depends on where you lived in Canada. So if you lived in Ontario, you may have good access. If you happen to live in, other provinces, especially some of the smaller provinces, you may not get access to that same treatment, or it may take you a lot longer in order to get access to that treatment. The other thing that really is important, though, is because a lot of these treatments are based on clinical trials for very small patient populations. We oftentimes push to have them approved and available with very short clinical trial timelines, very small clinical trial populations, creating what is known as a high uncertainty in terms of exactly how well do these drugs work, how long will they work, which subgroups, even within a rare disease, might they work best for? What is that value proposition? So the goal is to make the drugs available as soon as possible, but to be able to collect and to use data, continuously. So how can we get more information while the drug is being used, which is different than what we normally do. We believe that, we do a clinical trial, we make the drug available, we have it provided by oftentimes a specialist if necessary, but the post, access phase of being able to collect data, evidence after the fact, including adverse effects, including how well it works, and then bringing it back into the drug program, bringing it back into the health system to analyze it and say, okay, what is working? How well is it working? For whom is it working? What is the level of benefits? How long does it work for? That absolutely is not being done, and that's a big, big part of it. So the higher the uncertainty, the more important it is to have what we call a post, access monitoring program. The challenge is our systems aren't really set up very well to do that. Our doctors are not really set up to collect information. Patients are not really set up to be able to provide that information. There's not necessarily a database that can collect this information across our 14 different, jurisdictions that are providing the drugs. And there isn't really a responsibility for anybody to actually report back on this information. So we're continuing to make these drugs available, but we don't know what the long-term impact is. We don't know, how well they're working, and we don't know what could be done better. So this is one of the goals within this national strategy for drugs for rare diseases. Can we do a better job in terms of collecting and using the evidence? Can we set up systems that we can actually provide that information? We're still, I think the first part of it in terms of making the drugs available has been done. The second part in terms of being able to collect and use that information to improve the certainty around, the effectiveness of the drugs and the value of the drugs, we still need to work on it. And it's a critically important part because we are spending a lot of money, but, we need to make sure it's being spent in the right ways and that we're getting the value. We also want to invest in innovation. So as we said, even though, within the orphan drug plans in the orphan drug development in the US, we've had more than 1,000 new therapies. In Europe, had more than 500, 600 therapies. Quite frankly, it's not enough when you compare to the number of rare diseases that there are. I mean, there's some talk that only about 5% of the rare diseases actually have an approved drug treatment, which is kind of true and kind of not true. Remember what I said before, many of the rare diseases, are affect only as few as 1 in a million people. So that the number there is very, very small. Many of the conditions that we do have drugs for are the most prevalent ones, and altogether, they accommodate for maybe about 75, 80% of the population. But there are still many diseases which don't. We are doing single patient drug development. We are looking at singular treatments, and of course, not every disease needs a drug therapy or should have drug therapy. There's good care and treatment. There's good management and monitoring, and as we said before, prevention, identifying the causes of a condition, being able to intervene so that we do not have necessarily a child which will have a double mutation that could lead to a symptomatic, rare, serious condition is very important. So that becomes a part of the overall strategy, but also more innovation. Then, what are the other things that we need to invest in to create, gene therapies, cell therapies, other kinds of therapies? And even now, as some of these drugs have been in place for a long time, can we create, biosimilar or generic alternatives to these therapies that would make them more available, and certainly could be more available to more patients at a more affordable cost in terms of low, middle income environments, but even in terms of the regular drugs, in terms of high income countries where we can need to replace the drugs in terms of bringing in more therapies. So we've been very excited in terms of the drug strategy, but really coming back to saying we need more than drugs then. And in Canada, we have proposed, for the last 10 years now, an improved rare disease disease strategy, which, as I've been talking about, would focus on early detection and prevention, so having robust newborn screening for those diseases that could be identified at birth. We have in Canada now a national recommended list of diseases that we should all be screening for. We also need to make sure that patients, if they're identified, are able to get access to specialists, which would provide for them the best possible evidence-informed care, not necessarily drugs, but also early intervention. Community supports about 40-50% of patients living with rare diseases need additional community support. They may have the need for supportive social services. There's a huge impact in terms of mental health, psychological services. There's a need oftentimes for supplemental educational services. Patients who have disabilities will need access to mobility and other kinds of devices. And certainly for people to be in the workforce, sometimes it needs direct support to the persons themselves, but also to caregivers. Caregivers in Canada, unpaid caregivers, a recent survey shows, spend an inordinate amount of time providing care to patients, and that means time that they are either not able to go back to work, or they're not taking care, time that they actually have for doing other kinds of care in terms of family. So we need better, support for the other needs of patients. We need to obviously provide the access to the therapists, and this is what the drug therapy has done, and also the investment in that in terms of research, where Canada itself can be looking at the diseases, but also looking at gaps in terms of the kinds of innovative therapies and the devices that we could provide. So that's it. Thank you very much for your attention, and really appreciate the opportunity to talk to you about rare diseases, how they are manifest globally, and what we're doing in Canada to improve our access to diagnosis, access to care and treatment.
Well, yes, thank you so much, Dr. Wong-Rieger, for that comprehensive presentation on rare diseases across the globe and the challenges with diagnosis and access to innovative therapies. You've really given us a lot to think about. So yeah, we're gonna dive into our Q&A presentation, Q&A period. But my first question for you would be, because in our last webinar with Dr. Bruce Carleton, we learned about the benefits and breakthroughs of gene therapy. So what would you say are the main barriers of low-income countries in Southeast Asia that face accessing rare disease treatments?
We would think that it would be the cost of the treatments, but importantly, it's really the infrastructure, because, gene therapies is just one example, but most of these, innovative therapies are highly complex. They require a lot of monitoring. And as we said, we do not have absolute evidence in terms of how well they work and under what conditions. But you also have to be able to have systems to specifically diagnose. You have to have the specialist care there so that the patients can actually receive the benefits of the integrated care to make the therapy effective. But obviously, the cost of the treatments themselves can be hugely significant when you think about it in terms of the impact on a healthcare system that is already struggling to meet the needs. I mean, I've health ministers that say to me, look, we can't even cover off our infectious diseases. We have many challenges, even from very ordinary things like diarrhea. So, we're talking about, environments where taking the monies out of a traditional healthcare system and moving all of it over to rare diseases is not an equitable solution. We need to bring in specific solutions, and that's what we're working with companies to do. So, for instance, not just giving away, though some of the companies have, we have had compassionate access to, gene therapy like for SMA, but that means that you have to bring in a newborn screening program. You have to bring in the capacity to train the specialists in terms of how to actually manage and to diagnose and manage the patients. You have to bring in a lot of supports for the family and the system itself. So it's an overall solution that does require, support from from the companies, but also societies. We talk about the approach of compassion leading to sustainable access. It cannot just be compassion because that's not sustainable, but we can't just ask, countries to say, can you divert your income over to this? It's got to be a good combination, right? In terms of how do we make it more affordable, but how do we also help to sustain it?
Yeah, thank you so much for that response, Dr. Rieger. I just had a question that popped into my mind, as you were doing the presentation. Because usually, for instance, when we invent space technology, right, to go to the moon, for instance, a lot of the times we can take this, revolutionary state of the art technology and then reapply it to other applications, right, like on Earth. So a lot of like medical technologies actually came from, just this pursuit of like, space travel and everything, and, side effects, we can use it. So I'm just wondering, are there any like trickle down benefits from like, trying to develop these rare or like orphan drugs, and then, they can be applied anywhere else?
Almost all that we're doing in rare has had huge benefits for what we will call not only just more common diseases, but also for other kinds of scientific development. I mean, gene therapy is the easiest one to think about. It was really with rare diseases that we even looked at the Human Genome Project, understanding that many of these were genetic. If we could map the entire human genome and understand what a normal genome looks like, we can now be able to identify, right, when the patient comes in, where is it that you're deviating from normal? But this has huge benefits, right across, other diseases. But you think yourself, if you have ever done a 23andMe or done, Ancestry, DNA, all of that has come in to say, where's that come from? It comes from our interest in terms of the genome, and our genome really was driven by these genetic conditions. So it's come from the sort of trivial to interesting, all the way to, what can we do, as we said, for cancers, heart disease, liver disease, kidney diseases. We know so many of those that are very much, wrapped around the genetic definitions of specific mutations.
Yeah, amazing. Thank you so much for that response. Um, Given the high costs you mentioned about gene therapy, what policy solutions could make gene therapies more accessible globally?
I mean, some gene therapies, interesting enough, are developed for individuals. We have in Canada an amazing, example of a family which raised the money to develop a gene therapy for their son, who at that time they thought was just the only child that had that specific genetic mutation. And they raised $5 million, got the hospital kids in Toronto to actually develop the gene therapy. They developed 5 copies of the gene therapy with the idea of giving it away to other families that were identified, which they did along the way identify. The challenge is that, governments came back and says, oh no, you have to enter them into clinical trials. You have to go through all the regulatory hurdles you would need to do as if you were commercializing the therapy, never mind just giving it away. The UK just came out with a novel idea, and they say, okay, if you're going to develop a therapy for one family, we'll let you make 10 copies of it at the same time and allow you to use all 10 copies of it without further hurdles. So some of the challenges are regulatory, which can be important, but sometimes are not important when you think about these very small number of diseases. So we can reduce the regulatory hurdles to them. We can also improve, the ability to do clinical trials. I mean, thinking about clinical trial with a gene therapy, this is not very easy to do. When we think of our standardized clinical trial, you give somebody a placebo and you give somebody the real one, and then you look and see who affects. You don't really give people a placebo gene therapy. It doesn't work that way, right? In fact, we've got some gene therapies right now coming out that are for, they have to be injected into the brain. I mean, you really don't want to do that. This is not good practice. So we are now looking at things like synthetic patients. You're able to use AI to actually be more of a control arm. So can we reduce the cost by reducing the burden on the clinical trial? So that helps a lot. So part of it is, can we streamline, can we improve the development of it, reduce the cost of it, and then also then improve the access? Part of the challenge, though, is that it's a kind of a chicken and egg situation. The fewer patients that actually get access to a therapy that I've already created, or I think are going to get access because the cost is high, the higher I'm going to have to make the cost. The lower we can make the cost, the more people that could have access. And somewhere in there, there's a magic formula, right? Where you've got an optimal number of patients for a specific cost that will be cost effective for the company. So most companies are pricing their gene therapy as if only 2% of the population is ever going to get access. And we keep saying, what if we gave you 100% of the patients? What if we helped to develop the system? There are some ideas around nonprofits being able to take over the therapies. Really still very costly to develop, but you could have better cost sharing kinds of scheme. And I do think that into the future, as we have more experience with these therapies, it's sort of like space development, as you were talking about, Matthew. As we have some commercial entities coming in that are going to bring different kinds of economies into it, I think, we will do better. Right now, we're in that horrific, development phase, where it is going to take a lot of investment in order to make them work. It's going to take a lot of investment and a lot of access before you get that return. So if we can do a lot to increase the volume of patients that might be able to get access, the number of countries that are able to get access, we can do a great deal towards having to reduce the cost of the therapies and making it, cost effective for companies, researchers to develop them. It's kind of a funding problem more than it is a clinical problem.
Yeah, definitely. It sort of reminds me, I think in BC just last year, there was this case all over the news about this little girl with a very rare disorder. And the BC government I think they were going to get rid of the funding that they gave for her to receive the drug that would treat her rare disease. And this received a lot of actually public backlash. People were very angry, and eventually the government actually restored the funding. But it just goes to show that because, especially in a healthcare system that is very resource constrained, it's where do we allocate our money, and how do we allocate it, I guess, in a way that can benefit a lot of people, but also ensures that vulnerable people receive the treatment as well.
The sad news, as we all know, is that a lot of the challenges we have are not as well medical or clinical, right? The challenge in this case, we intervened, a lot in terms of the family, not because we had any idea whether the treatment was really working for her or not, but primarily in the process, to negotiate in the beginning. What are the start conditions? What are the stop conditions? But what they never did was, over the 5 years she was on the treatment, continue to collect the information to update how well the drug was working so that they had some real answers. I mean, the tragedy is to take her off of a drug that might still be working for her. I mean, equally, continue a drug and pay for a very expensive drug when you have no idea whether it works or not. Right now, we have no idea how well it's working for her because we have not put those systems in place. So, I mean, we have this notion called a managed access scheme or what we call outcomes-based agreement. It goes back to what I was talking about. Set up a follow-up system, and with a gene therapy or with any kind of innovative therapy that has to be given over time, what you can do is set an agreement up front. What is it that you need to start? What would you need to see in terms of the patient to demonstrate that it's continuing to work? And that does come from clinical information, et cetera, right? But you have to collect that information. If the drug continues to work, we continue to pay for it. If the drug doesn't continue to work, we all agree with the family that we do not continue to keep, a person on this treatment, and we do take them out. It's sort of like we know, my husband recently died of Parkinson's, and he was in palliative care. At some point, it became clear, he was not going to continue to respond to any added interventions, and we all agreed. And he had early on, when it is clear that we cannot do anything more to sustain quality of life and a good, duration of life, we don't do that anymore. So, but we need to have some clear understanding, right, as to what are, the conditions for stopping. So one of the ways we can make therapies more effective and more affordable is we set up agreements so we're only paying for treatments for people when the drug actually is working. Right now, I think all of us know there's a lot of wastage and there's a lot of misuse in terms of therapies. And when you talk about very high cost therapies, even small misuses, right, can lead to tremendous costs. And if we could turn those costs into paying for treatments that do work, again, it isn't a medical problem. It's a matter of how our systems are set up. So we need some good, business students to come in here and help, set up our systems, and in a way that we can get the best return on the investments.
Yeah, thank you so much for sharing that perspective. You did mention the importance of newborn screening programs. Could you perhaps elaborate on how countries can effectively implement these programs, especially in resource-limited settings?
Newborn screening, there's a core group of newborn screening tests. They're actually so well researched in terms of their value. Many of them are for what we call metabolic diseases. They include things like PKU, diabetes, CAD. So these are diseases that are built in, based on the metabolisms. If we intervene early on these diseases, we can actually keep the child from being symptomatic. We can actually keep the disease from progressing. And sometimes those interventions are changes in diet. Some of those interventions are really low-cost, nutritional kinds of supplements. Many of them would be very highly effective, even in low-income, highly, resource, deficient countries, right? So we already understand what that core group of diseases should be. There's 50 of them that are highly, highly so. There are about 200 of them that are cost effective to do, and they aren't that expensive to do, because many of them you can do as a panel. I can do 20 of them at one time, and the challenge is the ability to read them and to be able to provide an accurate diagnosis, right? Canada finally, with this newborn rare disease drug strategy, one of the important things we did was to implement across the country a consistent panel of newborn screening tests. This is great. And all the provinces were saying, here's monies, implement newborn screening. We are probably, 40 years behind the US in terms of doing this, but it's okay. We're still better than many of the European countries, but if you can understand the economics of it, God, it always comes back down to economics. It is cheaper to screen, to diagnose, and prevent these diseases from becoming symptomatic than it is to not screen and to then have to deal with the disease, either in terms of the impact in terms of, disability and the challenges for the families, but also in their ongoing, cost. So newborn screening is probably that low-hanging fruit. It's easy to do, cost-effective to do, and really, standardized in many, many environments.
All right, thank you so much. We just have a few more questions before we wrap it up. So, The new and proposed World Health Assembly resolutions on rare diseases frame them as a global health priority for equity and inclusion. How do you see these resolutions changing what happens on the ground for patients?
They're not magic. I mean, just because the World Health Assembly, World Health Organization says thou should, deal with rare diseases, countries are not going to turn around and say, okay, we will. However, all 194 countries in the WHO signed on to it. It gives us as patients in the healthcare profession as well, huge opportunity to advocate to the countries to say, you've signed on to this. Now let us help work with you to actually bring in a strategy. So that's the first thing. It gives us a right to ask. It gives us a right to say we have a right as rare disease patients to the same level of healthcare and the same level of support as patients with more common conditions. So that's number one. Number two, though, we are working, as I said, I'm head of the Asia Pacific Alliance. We're working on an Asia Pacific, a regional strategy, because we recognize that rare diseases, as we talked about, are defined differently, they're set up differently in different countries, but within a region, we can help each other. We can learn from each other, and we can also share resources across countries. So it gives the opportunity then with the WHO to develop some regional solutions. We last year were in Kuala Lumpur and in Indonesia putting together a Southeast Asia Alliance resolution. So we will use that to help us do the advocacy, do the development within countries, but each country is going to have to look at their own resources, look at their own capacities, but as importantly, look at where the priorities are. The rare diseases that cause me the most grief. We were in the Philippines and we were, the Secretary of Health there. They have several diseases that are high, need. They have the best newborn screening program probably across all of Southeast Asia. What are the diseases that cause us a lot of costs, patients coming into emergency, patients actually requiring a lot of assistance if we don't diagnose them? What can we do there? So we need to, in each country, kind of help ministries identify where their highest need is, what their capacity is, though. Not every country actually has the capacity to do newborn screening. The Philippines, has 9,000 islands. They have to collect, samples across 9,000 islands. The Indonesia says, we have something like 20,000 islands. We have very uneven healthcare. So what can we do to start? We have to, I think, work with each country within the capacity that they have. But if every country, learns from each other, shares some of those resources, does a bit more, I think that is the key. Without the notion that says, is equity possible? Not equity if you expect everybody to have the same standard, everywhere. No, it's not going to happen. In every country, make rare diseases a priority within their healthcare system, yes, we can do that.
Yes, thank you for that. Matthew kind of mentioned earlier about advocacy, like many families must become kind of expert advocates just to access basic care. So from an equity perspective, how do we reduce the burden on individual patients and families to navigate complex systems?
Yeah, I mean, in many cases, right, especially for rare disease patients, so some of them do have it in the family. You do not kind of start a family thinking, okay, I'm going to have to learn about how I'm going to get, diagnosis, care, and support from my child. You kind of assume that, either everything's going to be okay or the system is there to help you. So that's the sad thing, right? Most people have no idea. I get calls, letters all the time from people that says, what do I do about this? How do I get a diagnosis? How do I find a specialist? How do I get access to this treatment? It is very challenging. So unfortunately, we don't have, a lot of systems in place. I mean, CORD across Canada, we are a very small organization. Our ability to help individual patients is very limited. If we're lucky, there is a group that we can send them to. You have this. There is a rare disease group for your particular condition that we can send you to, and hopefully you can learn from the families that are there in terms of how to advocate. But that is the challenge, right? If you have cancer, okay, you've got cancer centers. If you have diabetes, there are diabetes centers. If you have a kidney disease, usually it's a kidney clinic you can go to, right? Unless, of course, you have a rare version of those. And then even there, the specialist may not be diagnosing you correctly, giving you the right care. We're a long ways from, I think, being able to help patients. Even AI is not that good because AI is dependent on crowd data, right? And so if your crowd is really, really tiny and the known resources are really, really small, AI is not going to be that much help to you. In fact, AI could be horribly misleading, in those kinds of situations. But we're seeing more, that are able to do it. But it really is falling a lot on patient associations. We're getting more global patient associations that are trying to reach out across the globe, but unfortunately, I wish there were a good answer. I wish there was a Bible. I wish we could say, here's a great resource. I wish they could say, come to us and we can help you. We can't. So it's hard, but we're still very much a long ways from being able to help, families as much as we should be.
All right. We're just gonna wrap it up with one more question. Like looking ahead, maybe like 10 to 15 years, what would we need to change, in policy and financing, maybe in the culture, for it to say that equity in rare diseases across the globe is genuinely within reach?
Matthew, this is a wonderful question. And it's exactly the segue I would like to have to say. We would like to thank the federal government for their initial $1.5 billion investment in a rare disease drug strategy. What we need to do is make sure that is not the only strategy that ever comes out. We want phase two. We need to have at least another 3-year strategy. And maybe like the cancer control strategy, we have ongoing investments because these are rare diseases. So provinces will be stretched in order to be able to cover them. They really still require a lot of investment in, research and diagnosis in order to do that. So we definitely in Canada need ongoing investment. It's our job now that we've had access to the first one to propose where we think that money should be invested, propose initiatives that would help to optimize the use of that money. But we definitely need to continue the support of a national system. Globally, I think we need to work more together now to say, okay, what are pathways to sustainable access within a country? If a country has willingness, it's a top-down, bottom-up approach, right? Top-down, government say, okay, we can do this, we'll provide this, we'll support this. Healthcare system says we can do this, we provide this. Bottom up, patients advocate says we can help contribute to this. Realistic, right? For me, the notion is what's realistic. So I think we've got a lot of good things in place. You asked before about the World Health Assembly resolution. That is a big help to getting to where we, get some incentive for countries to support, but we still need a lot of, support. And the pharmaceutical companies, I think they need to play a bigger partnership role in terms of supporting not just getting the drugs to people, but the development of the infrastructure, the data collection and analysis, so that we can be sure that we're going to get the best value for this. So yeah, we need another strategy here. We need ongoing investments.
Yes, well, thank you so much, Dr. Wong-Rieger, for your time to join us in today's webinar. We've really learned so much about your insights on rare diseases across the globe.
And really, you folks are doing an amazing job in terms of your association and doing the outreach there. So I thank you for the opportunity.
Thank you so